Good afternoon, everybody. Thank you for attending this Health Monix webinar. Hope everybody's having a great day. What we're going to start on this webinar here, and what we're really focusing on is navigating MSSP quality measurement in 2025, and giving you a large overview of a whole bunch of various different topics and what we've learned, and some great education material as well. Looking forward to speaking with everybody. My name is Stephen Tyson, Senior Account Executive here at Health Monix. I've been here for a number of years working with ACOs specifically on quality strategies and finding success in these programs. I'll also kick it over to my colleague Mike to introduce himself as well.
Good afternoon, everybody. Mike Lewis here, VP of Customer Success. I've been working in the healthcare quality role for almost a little over 10 years now. So bring with it a lot of experience working with ACOs all the way down to the individual practices that work within them. Look forward to this presentations and your questions and from it.
Thanks, Mike. And just a little reminder here, handouts and questions. We will be sending you this material in an email after the webinar as well, for everybody who has signed up. So the objectives of this webinar, as I mentioned a little bit briefly, is understanding the evolving quality requirements for MSSP ACOs, and then also giving material and education on how to navigate, learn, identify, and assess different types of reporting changes, and learning from the previous year's experiences and exploring lessons off of that. And then also really identifying areas of performance improvement, and to be able to not only leverage where your organization is now, but as these programs continue to get more challenging and mature a little bit more, to identify performance of improvement, and then also assessing the quality measures for ACO success. So a little bit of a rundown of the 2025 MSSP program. From our research, MSSP is really still the largest value-based care initiative under CMS, and it's really designed to incentivize ACOs to report and improve quality while reducing costs. Really, nearly 500 ACOs will participate in the MSSP program come 2025. And then, as I mentioned in a previous slide, it continues to evolve with updates impacting ACOs in terms of increasing in measures, participation, and then also financial incentives that lead to that. So achieving the shared savings program, as I mentioned previously, the evolving CMS regulations, and then also shifting to digital quality measurement. What we're looking at here is to be really able to minimum for quality performance and required to earn shared savings at the maximum rate, and then really taking a look at quality as a multiplier. MSSP ACOs must meet minimum quality performance thresholds to qualify for the shared savings under the MSSP program, and then also being able to, while in the program, CMS is continuing to raise the performance benchmarks for ACOs to improve year to year and maintain eligibility within the program. So that's something that that we've seen throughout the years, and as it continues to evolve. So really shifting the quality reporting for MSSP ACOs and what that looks like. So the biggest change for coming up for 2025 is the removal of the web interface. So ACOs had the option to report for the web interface, but also while being able to track different various areas, as you'll see here, for the ECQM, CQM, and Medicare CQM. So you had those areas to track and potentially report on. Shifting back the requirement to report on all Medicare patients' quality measures, and then coming forward, what that can result into is need to report on data for millions of patients, and that's a heavy lift. We've seen that time and time again over the years, and then also being able to, for ACOs to, new methods to may require inclusion for specialist data.
All right, I'm taking over here. So great time, by the way, to start. If you guys have questions, we will try to get to most of them on this call. However, we will, reach out to you afterwards if we couldn't get to your question during this presentation. So quality reporting requirements in 2025, CMS is implementing significant changes. So the big thing is that they're giving more options while they're taking away the CMS web interface. They are also streamlining everything under what's called the APP Plus quality measure set. That's the only way that ACOs will be able to report. The old APP measure set will be available for other provider types and groups, but not for ACOs. ACOs are going to need to report through the APP Plus quality measure set moving forward. Um, they're working on a phased expansion of measures. You come from the world of the CMS web interface where there were many measures, dropped all the way down to really only three CQMs over the last couple of years, but they're going to bounce that back up, and it's going to become very similar to what you've seen in CMS web interface, with a lot of their choices for measures around their strategic plans for quality reporting in the future. And then as they move forward, what you're going to see is the stream from your Medicare CQMs and CQMs to ECQMs only. And then further down the line, we're going to get into digital quality measures. The more robust their program becomes, the more they are going to become dependent on technology to lessen the burden on providers and groups and increase the interoperability between not only your ACO, but the practices that are around your lying ACO, as well as all the other ACOs, where data sharing can help patients across the entire country. So the introduction to APP quality measure set. So now starting in 2025, you're mandated to do that. The new set aligns with the adult universal foundation measures. What's important about that is not only is it the adult universal foundation measures for this new measure set of APP plus, but that's where it is going to start aligning with some of the other programs like um, uh, the Medicaid plans that are available, the START program that's out now, as well as the MVPs for primary care, are all going to line up under this adult universal foundation, really getting it so that the exact customers that are reaching out and not, the exact patients are getting what they need from this program, and they're getting the data that's needed for government reporting. Um, they also are introducing a complex organization adjustment. Basically, what that's going to allow you to do is, if you do report ECQMs, which at this point is probably the more difficult of all of the options there, you can and you meet the data completeness in the case minimum, you're going to get an extra achievement point for each of the ECQM. So in 2025, that could be 4 additional achievement points for the 4 ECQMs that you can report. So we have the 4, as I said, 4 electronic ECQMs or CQMs, or the Medicare CQMs, right? You have the 3 different options for reporting in 25. We have diabetes that has been here, preventative care screening for depression, as well as controlling high blood pressure. And then the new one for this year is breast cancer screening. However, it should not be very new to any of the groups that are out there, as breast cancer screening has been a MIPS, PQRS, meaningful use, you name it, measure for a very long time. You will be scored on only one administrative claims-based measure. They took the other one away for 2025, so it's just the hospital-wide 30-day all-cause unplanned readmission rate. And then everybody's going to have to do the CAPS for MIPS survey. So that still is going to stay in every category for ACOs to report. So their plan is, and I go a little more detail on a future slide, but colorectal screening will be coming in 26. In 27, we're going to be looking at the engagement of substance use disorder treatment. And then as early as 2028, we'll be looking for screening for social drivers of health and adult immunization status. Now, coming from myself and my experience, what I do see here are some very difficult measures that are coming in the future, things that are going to take a little bit more time and a little more planning as we're getting there. Uh, the social drivers of health and adult immunization status have been around in MIPS now. This is their second year in 2024 reporting. So 2025 is their third year for these measures, and there are a lot a lot in these measures. They're what we call multi-strata measure, and there are lots of answers that are needed for you to, that's the adult immunization one, multi-strata measure. There's a lot of answers you need to do. It's a lot of the old measures you're used to combined into one measure. And then the screening for social drivers of health that really pushes at their whole plan and moving forward with health equity as we move forward. So we are eliminating some of the reporting options. So as we said a couple times now, the CMS web interface is gone. The last year to do that was 2024, and submission deadline was um, earlier earlier in this year. And then over time, CMS is planning to phase out Medicare CQMs and CQM reporting. But at this point, there is not a steadfast date. I can tell you that maybe the final rule offer dates in the future. However, that is very much subject to change as it has over the years with every category and every reporting requirement for ACOs. So I expect that Medicare CQMs and CQMs are going to be around for a bit longer than CMS is predicting. There is an emphasis on moving towards the digital quality measures. So the CQM, the ECQMs are a good step in that direction as they need to be utilized using CERT 2015 certified or a certified EHR system. And the DQMs are just another step in that direction. You know, there's a lot on the internet you can look at to look and see what they mean by DQMs and how it's going to impact you and what you need to do. But a lot of it is going to be data that is, you know, directly related from your EHR into registry reporting or directly to CMS with this data. The more that they can get uh, move towards this digital frame, the less burden it will be on especially those smaller practices that are part of your ACO, as well as some of the specialists. However, the big impact on those guys are going to be that you will be needing to use a good EHR. Some of the mom and pop EHRs that are out there, as well as the uncertified ones, are going to become obsolete for anybody that wants to move forward in any of these programs. So there's a lot on this slide. If you've been on my webinars in the past, you've seen this before. This is a breakdown of what it looks like for the APP Plus as we are moving forward. So in 2025, what I share with you is the 4 ECQMs that are there. ECQMs, MIP CQMs, or Medicare CQMs, administering the CAP survey, as well as your claim-based measure. And then if you do all of that, so the top line, what you see there, if you do all of that and you are higher than the 40th percentile, you are eligible for max savings. The other option is if you meet the alternative quality performance, which is really that you are reporting data completeness for all of those measures. You do have to participate in CAPS and everything there, but you need to report higher than the 10th percentile on at least one of the 3 outcome-based measures, as well as the 40th percentile on one of the remaining 5 measures. You can still participate in savings, but at a lower rate if you just have a score higher than the 10th percentile for at least one of the 3 outcome measures and not participate in everything else. And then if you do not report any of the quality measures and you do not administer the CAPS for MIP survey, you will not only make yourself not eligible for shared savings, you will actually owe maximum shared losses. So participation is a must. As you can see moving forward, and I'm not going to go through each one of these on here because I have two more screens to show you future years. You in 2026, we're adding a fifth measure and a second claims-based measure onto that, and it's the same sort of study those years for how you can participate in maximum shared savings. In 2020, this is should be 2027, not 2025. I'm sorry about that, but that's 6 measures, and then we have the CMS will calculate 2 claims based. As we move forward, the same thing in 2028. The one thing about 2028 is that measures 487 and 493 won't become available as part of this program until they've become an ECQM for at least 1 year. So we are looking into when they're going to move those 2 measures from just the CQM into an ECQM. So here's a little bit of a collection type comparison. So the patient population for Medicare CQMs are going to be Medicare only. Both CQMs and ECQMs are all patients and all payers. The data requirements, manual chart abstractions, and EHR integration for Medicare CQMs. A lot of almost any you could manually enter information into a registry for reporting Medicare CQMs and CQMs alike. It does make it a little easier, but it does make the benchmarks a lot higher and harder to attain because many people are doing very well on both of those. The ECQMs actually, for the ECQMs, electronic health records, you need to use a 2015 cert or a certified system, and you can abstract the data for an ECQM. It can't be manipulated. Um, the Medicare, the MIP CQMs, I know we have in here. CMS did say that they want to be stopped after 2026, but I don't think that's going to happen as I don't think they're going to be prepared to do that by 2026. So I think once again, 2026 is the year, but 2028 is probably what we're looking forward to. So measure achievement, as we're going for quality measure scoring, measure achievement points are determined by comparing performance on a measure to its measure benchmark. Benchmarking for these measures are interesting as we have 3 different measure types that we're trying to benchmark against the entire time. So the way a measure can be benchmarked is one, if it has a benchmark available. So that means that there is historical data from 2 years in the past that will allow us to work with, will allow you to approximately know where you stand when it comes from a point standpoint. The volume of cases you submit, so you need to have 20 cases for each of the CQM, ECQM, Medicare CQMs, 200 cases for hospital-wide, 30-day, all-cause unplanned readmission, as well as for that. So as an ACO, there's no way that you're going to fall under any of those categories. And then you need to meet the data completeness requirement. That's probably the hardest and the number one that you're looking to do to get in there. So you need to report on at least 75% of your denominator eligible instances. And that way your measures can get benchmarked. There is a complex organizational adjustment, as I mentioned earlier. This is beginning this year in 2025. If you are reporting ECQM collection type, CMS is going to add 1 measure achievement point for each of the ECQMs you submit. It can't exceed 10% of the total available measures, as well as it can't go over the points, maximum points for the quality report performance category. When it comes to data completeness, it's been around a while now. So if you need extra information on this, we've done some webinars as well as have a couple of documents that we can share with this. But it's 75% of eligible instances. That's across your entire ACO. So if you have specialists that are in your ACO and they don't have attribution, if they still have eligible instances, you need to be reporting on that information. So, it's not that CMS wants you to pick 25% and say, I don't want that. It is just giving you that opportunity to, ramp up to get as close as you can to 100% in the future. That will be moving up in the near future. And then Medicare CQM collection type is intended to address some of the data aggregation, and that's what we're going to talk about as we move forward. Here's just a graph of what it looks like for each one of the measures and what they are adding on. In 25, you could see 6, and then it moves to 8, 9, and then finally 11, and that's going to match up against the adult universal foundation measures. You can see the measure 484, excuse me, 305. Nope, 484, I was right the first time. 484 was included in 2024 reporting, and then in 2025 they took it out because it's not part of the adult universal foundation measure. And then they're adding it back in 2026 as they move forward. So you can see that they have a streamline of what they want to be able to do here. All right, I'm going to move it back to Steve for a little bit.
Thanks, Mike. Appreciate it. So Medicare CQMs, they're a collection type that allows data on a smaller subset of patients within the ACO. And really how I kind of describe them is it's a compromise from CMS to allow ACOs to be able to collect a little bit more of a concentrated data type of collection. So they allow it to you all to collect it on a smaller scale, unlike the all payer, all patient, where you need to be able to um, get all of that data in there in one subset and over. But with Medicare CQMs, you still need to aggregate data from all sorts of different systems and report on them from there. Um, and then also, they are all beneficiary measures, not just an ACU assigned beneficiaries, and that's very important to understand. And it's a list of beneficiaries that are eligible for Medicare CQMs that will be delivered to you from CMS on a quarterly basis. And then what is also very imperative to understand as well is they are a part of the health equity adjustment that comes from reporting Medicare CQMs. So to go in a little bit more depth in detail from a previous slide that Mike spoke on benchmarks for Medicare CQMs, what we're looking at here is that they're going to take the benchmarks from the first 2 performance periods on these measures and then apply them. So you'll see right here for 2025 only, you have 134, 236, 001. So then what you'll do here is on the measure for 112, you're going to take 20, it starts in 2025 and 2026, and then in 2027, there will be historical data from both of those measures. And so what you'll see right there from on, you use that math logic there, and that's where the benchmarks will be given back to you, and where the measures will have benchmarks that you'll be able to take a look at from previous years. And just to give you a little bit more of a rundown of what the list of beneficiary for eligible Medicare CQMs, what it provides. As I mentioned in the previous slide, CMS will deliver that roster to you on a quarterly basis, and it's going to be a list for beneficiaries eligible for Medicare CQMs. And some of it, what it entails is the key information that's based on the Medicare claims data. So as you'll see right down there, eligible age, and then eligible encounter, and then how the data can be used. And what's important about that is you'll be able to match the measure specifications on different types of data, diagnosis, encounter, and age criteria as well. So that's really what the list that for the beneficiaries that will be provided back to you for Medicare CQMs and how you can leverage that for your organization.
All right, back to me, right? So working with our organizations and ACOs, working through the beneficiaries and how to work with each one of them is unique. I will tell you that. I don't think that there is a single answer for this is how you work with ACOs. I think there is a strategy that can be involved. But when it comes to ACOs, utilizing this method and utilizing your Medicare beneficiary file can be very useful in being successful. So can a ACO use the quarterly list? Yes, the Q4 list, the quarter four list includes all Medicare CQM eligible beneficiaries. That is delivered in in February of the following year. You will get one quarterly, so you can track that, but know that it's behind, so that there's going to be work that you're going to need to do in the quarter while you're seeing the patients, that you should be tracking this data for your eligible Medicare patients or all Medicare patients if this is the only way that you're going to report, so that when it comes time for you to synchronize and figure out which ones are eligible for the metrics for Medicare CQMs, you're not surprised at the answers that you have received. Um, I think that this list can do very well for you even previous years. So if you've been in an ACO before, you do have, last year's lists to work with. So how should you use it? You should use it to understand what patients are included, kind of understand where they're coming from, which providers are seeing these patients or being attributed these patients. The list does include each of the providers that sees a patient that's part of your ACO, so you're able to see if this patient is going, inside a hospital system, for instance, or one of your partner practices as you're moving along. Identifying and understanding what those exclusions are. So a lot of exclusions for these measures. Hospice care is one of them. Age ranges have some exclusions for the depression screening. It's a history of bipolar disorder. So understanding those exclusions and being able to teach your physicians who you have to ask these questions to and who you need this information from. The one thing that this does not provide, it does not provide any numerator data, as well as it doesn't provide any dates, visit dates. That's actually something I find interesting, and I do think that CMS should include the visit dates that these patients were seen. However, they don't include it on this beneficiary file. ACOs can identify the denominator beneficiaries on their own without the quarterly report. It is helpful for you to understand that stuff, as I said, because the quarterly report does come in after the fact. If you're able to identify those patients, you need to make sure you are doing these quality actions on prior to them coming in or while they're in the office. It is more important to do that than it is to try to find the answers that hopefully that your practitioners had filled out during the previous quarter. You must use complete and accurate data to determine eligibility. When CMS takes all of that data in and you don't have them in your ACO as a diabetic, but they saw a provider outside of your ACO and they marked them as diabetic and put that claim into CMS, then they're considered a diabetic for the year. Whether that's a mistake or not, or whether it's the right thing, is not for me to judge on that. But we have seen it before where a provider was said that this patient doesn't have diabetes. And when they were able to get their information, they realized that they saw someone outside of their care who marked them off as having diabetes. And then, as I stated, you can't identify the numerator status using the quarterly list. It's really just the denominator. It's really just eligibility, and does not include anything about the patient for any of them. It is a qualifying for the patient measure. It is not giving you any answers for the patients. So here are some challenges for Medicare CQM versus ECQMs. So Medicare CQMs, you have the limited time for processing them. As I said, once again, these are given after the fact. Quarterly lists are provided. The last list isn't available even until February of the following year. We had until yesterday to report CQMs and ECQMs and Medicare CQMs this year, but in most cases it ends on March 31st, so that really only gives you about 25 working days, business days, for you to gather the information needed for processing if you waited till the fourth quarter to do so. Incomplete patient information, so it doesn't include things like age, or it only includes age, diagnosis, and encounter data. It's not including any of the numerator data, patient visit data, and things like that. It eliminates the ability for you to get that extra ECQM reporting incentive, as well as, we do have the measures here for, or the benchmarks for Medicare CQMs changing in the future. But that Steve was talking about the flat benchmarks and so forth. But the compared CQMs to ECQMs, the benchmarks are astronomically different. And I suspect that once we start seeing the actual historical benchmarks for Medicare CQMs, you're going to see very high benchmarks, especially for Measure 134, where you'll have reporting rates in the high 90s for Medicare CQMs, and making you get into the high 90s to beat the 40th percentile would be my guess. And then limited time frame, these aren't going to be around forever. They will be here for a while, but they're not going to be around here forever as they are pushing towards the ECQMs or DCQMs. Some of the benefits of the CQMs: easier data validation. You're able to check everything, look in the EHRs, use supplemental data, find where you can, find out where you can get that information and utilize it for reporting. It doesn't require full EHR integration. We have people that we've worked with, small groups that are still on paper charts or are on their own EHRs or small EHRs that aren't necessarily certified. So there's a lot more options when doing Medicare CQMs to ECQMs when it comes to that. And it supports multi-source data aggregation. I know ECQMs does as well, but there is more stringent outlines of when it comes to ECQMs and being able to use only those certified EHRs to have them come in and map together and report on. So, uh, you know, Medicare CQMs does offer a little bit more control over what you're reporting, a little more insight into what you're reporting prior to submission. Allows you to find data that might not have been documented correctly compared to an ECQM. If it's not in the QRDA1 or if it's not in the file transfer, then it's not going to count for MIPS reporting. So working with the ACOs that we have over the last couple of years, identifying critical areas for performance improvement. There's a couple things that, you know, really want to get into and can get into as you're building out your own strategy. But I wanted to give a little insight into the 4 measures and some of the challenges that we found this year when it comes to each of the measures. So for measure number 1, which is your A1C, that's percentage of adult patients 18 to 75 with diabetes. It's an outcome measure and it is inversely scored. So the lower the number, the better performance. So some of the challenges: pulling A1Cs from the appropriate source systems. They don't have the data in the right area a lot of times. We have found things where PDFs were uploaded into the file of their lab results. Not every patient goes and sees one of the big labs like Quest or LabCorp, and that data that we have allows it to it isn't able to be absorbed into the QRDA1 files and so forth. Determining why a particular patient is failing the measure. So there could be 2 different reasons, right? There's no A1C taken on a diabetic patient, or the A1C is not within range. So understanding why is this patient not meeting this particular measure. Inverse measures, for most hospital systems, very well accustomed to these, but the smaller provider groups within the ACO, a lot of times they have a hard time understanding that the lower the number, or in this case too, the not met instance is what you want. You want it to be not met. Met instance is bad here. So understanding that algorithm sometimes is very confusing when you're talking to when you get down to the physician or the physician helpers as you're doing that. Because it's an outcome measure, you won't achieve 100%. Maybe an individual provider only has 10 diabetic patients and they're all well controlled. Congratulations, that's awesome. But from a whole standpoint of your population, you will never be at 100% for this. So there will be a point where this is not going to be a perfect score. You can fall in above the 50% mark is really good for this, and the high 80th percentile is where we're seeing a lot of people end up. In the mid, from the mid 70s into the 80s is where you'll be. Specialists don't have access to the needed information, so if the patients only saw one of your specialists, maybe they don't have results of their A1Cs. And as I stated earlier, the data may not flow from the patient's lab into your EHR. For measure 134, this is the depression screening. You need to use a standardized tool. If they are depressed, you need to have a follow-up. That's what makes this probably one of the harder measures. And one of the things in this as well is that the only way out is if you have bipolar disorder. So it's going to include so many more patients. I've seen as high as 200 times the number of patients for diabetes have been involved in this measure in the depression screening measure. You do have the ability to collect the data 14 days prior to a qualifying encounter, as well as the follow-up needs to be done within 2 days after. So if that information is documented like that and you have information that has been shared with the patient for follow-up, as well as uh, you can do the depression screen before, you can count for this measure. Um, Specialists have felt uncomfortable administering this measure. It's been part of these programs for a long time, but we've still run across providers that don't feel comfortable asking about depression if they're not the ones that are treating it. It is a two-part question. A lot of times, QRDA1 files document that you had done your PHQ-9s or you've done a depression screening. However, if it's positive, a lot of times the documentation for the follow-up is not accurate. So it's really important to understand what your EHR does and what your practices individually do for the follow-up and make sure that it's documented correctly, because either not doing a depression screening or failing to do a follow-up on a positive both give you a negative result. So they both harm you in the same way. For measure 236, this is for your hypertension. Uh, I think some of the big parts are that most practices that are in ACOs and even elsewhere are doing blood pressure, because you could do that directly in the office, unlike the A1C for the most part. But a lot of times they aren't mapping to the right field. A lot of times they put information for each of the different scores that you need, or the two scores that you need, into the wrong fields. And that obviously is going to mess up the calculation for the measure. There are, once again, you're not going to get 100%, very similar to diabetes. So, the ways you don't get it are if the BP is not within range or there was no BB taken. And then sometimes, there are specialists out there that aren't doing these measures or aren't taking blood pressure. The newest measure that we have here is breast cancer screening. So this evaluates how well healthcare providers are ensuring eligible female patient population is receiving their breast cancer screening. Um, the unique part about this measure is the timeline. I think that's the hardest part of it. The time frame for it is a screening needs to be done in the past 27 months. So you're going to need data from previous years allocated in this. It is a measure that is new to the ACOs this year, or new again to the ACOs this year in 2025. And there are a lot of exclusions. So understanding your population base is very, very important. Couple lessons from previous years. So we've partnered with ACOs for the past 3 years, grabbing data for ECQMs as well as MIP-CQMs, and even reporting a number of ACOs this year for Medicare CQMs. We have a proven strategy for current year reporting, so it's important to get started early is something that we've seen, and then process improvement. So understanding that your first year is not going to be perfect. It is going to be good. You're going to collect the data. We're going to work on improving, but building up a year over year plan to help you become elite in this is where we are helpful with. We've worked with ACOs from a single EHR all the way up to having 100 different data sources that are coming into the system, customizing our strategy based on each client. It's their data. So how is your data? Where is it? Is it, all over the place? Is it in one central location? What your knowledge is as an ACO, as well as what type of staff requirements you have. The right partner and the right strategy is going to maximize your shared savings and your score. And then, I think I can't get across it enough. I come from the sales world where we always say, "Oh, we got it. It's easy." Now I'm in the customer success world, and I will tell you that ACO reporting, they don't make it easy. We make it easy, but CMS is not making it easy. And getting started earlier, finding the right partner is really, really important. So 6 things we've learned. Understanding who's in your ACO. You'd be surprised. There's a lot of changes in ACOs, especially when you have practices outside of your main hospital system that change every year. So understanding where each one of these clinicians are coming from. Understanding what data do you need? Do you need just data from your EHR? Are you going to need it from lab information? You know, is it in Epic? Is it in Caboodle? Is it in Clarity? Where do you need to get that data from to bring in and report on? Finding the data is important and can be challenging, especially the more EHRs that you have and the more small practices you have. Getting that data and finding where it is important. Data isn't always where it's supposed to be. I always made the joke that when I used to do one-on-one consulting with practices, that a provider would ask me, why can't you see XYZ? And I would tell them, well, because you uploaded a picture of a depression screening score with the smiley face circled. You're not going to get points that way. No one's going to be able to read it that way. So I make that joke. And then validating data has become more important. So understanding the data that's coming in and not only, making sure data's in, making sure the data is accurate, making sure that the data that you have is what's needed for this. Is it the latest score? Is it information are we missing information that this patient was in hospice? Are we missing a visit from a provider outside of the main hospital system? There could be a lot of reasons, but making sure that we have all the data is important. And I put it in here again, but this isn't always easy. But we, as a team here at Health Monarchs, are here to help. So I'm going to pass it back over to Steve-O to take us home. Great
Thanks,
time
Mike.
to ask questions.
Much appreciated, and I'll harp on what Mike just said. It's a great time to ask questions. So main takeaways, as what Mike and I have reviewed here today, is understanding the Medicare CQMs, what the benefit is, really understanding the program and how you as an organization can leverage that with a partner like ours here at Health Monix. Learn from the past and improve. You've had years to build your ACO structure up. So how can you learn from the previous experiences, whether that's data acquisition, where the data is? I know Mike had mentioned, specifically with Epic, Caboodle, Clarity, but you know, as we've partnered with ACOs across the country, a lot of them usually have more than one, two, or three HRs. So where does that data live and what that looks like? Identifying your critical areas for improvement. Whether that's data acquisition, structure, or measure as well. And then, as Mike has harped on, and I'll harp on as well, start earlier. Put yourself in the best position possible to be successful within these programs. Start with a partner that has experience and can lead you and direct you in terms of strategy from year to year, as your ACO might change from one year to another year as you physician recruit or grow. We'll be able to assist you. But again, starting earlier, as Mike had said, this isn't easy, but we make it look easy here at Health Monix. So really helping your ACO succeed with these reporting structure, as we have gone over with the ECQM, CQM, Medicare CQMs, leveraging a partner here like Health Monix with our best-in-class US-based support and integration teams, all the way from the start of discovery calls all the way up to submission. We're here to assist you throughout the year and being able to leverage what your data strategy is from one from one month to another month, potentially to 1 year to another year. Having a partner like us to be able to lead and direct you in that and strategize for what's best for you as an organization is very important. And obviously, providing the highest quality of healthcare to your patients and why we are in healthcare in general. To review a little bit more what the looks like, as Mike had harped on and as I had harped on earlier, identifying reporting challenges, identifying all patients that are included, and then really the sheer volume of data for all payer data and even Medicare CQM data. Really taking a look at that sheer volume of data, completion of data, and collection from all different TIMS EHR systems that I had mentioned before. We work with groups that have potentially over 50 to 100 different EHRs and data instances. So really identifying that and strategizing what that looks like, the patient deduplication process, patient matching across all providers and all electronic systems, being able to hone in on that strategy and what that looks like when patients are potentially being seen and have to be deduplicated. And then obviously continually to collect and aggregate and view and report your data, being able to report and view your data in a real-time basis and being able to see where you can potentially leverage different strategies, performance enhancement, improvement opportunities, something that you'll be able to see and to continue to grow throughout the year. And then performance on quality measures and needed benchmarks, as Mike had alluded to before, being able to take a look at what those benchmarks look like historically, but then also I'll also mention measures that will be potentially added now and in the future to be able to take a look at how to strategize that measure strategy. And this is a little look at what it looks like potentially within our system and what it looks like for performance summary, being able to take a look at your performance in real time per measure and to be able to see where your improvement can potentially be and where you need to improve either across either EHR, a TIN, or a provider. To be honest with you, to be able to compare and contrast what your providers look like and their performance per measure is very important. That's something obviously that we strategize with you in and be able to leverage now and in the future in terms of different strategies for measures. As we conclude here and wrap up, obviously feel free to ask Mike or I any questions. We are great resources to be able to help strategize your ACO in terms of what you should be looking to do and how we can partner with you to best leverage the strategy for success for your organization. You can take a look here. You can shoot us an email, give us a call, or you can also visit our website, ACO Impact, be able to sign up. I'd be happy to take your organization through what a potential strategy could look like for success. And one last slide here. We are going to be at NACOS in the next week, the 22nd to the 24th. We will have a booth, the booth 28. Feel free to stop by. I'd love to speak with you, talk with you. If there's anything that any questions I can answer, or if you have any questions for specific strategies that potentially, I can walk you through. Would love to speak with you. Feel free to stop by. At the very least, we'll have some chocolate at our booth.
Better be Hershey's.
And we'll have that. Maybe some Reese's too.
Nice. All right. So stay tuned for our next webinar. We're going to have a bunch more webinars coming up now that submission season's done and we could breathe for a half minute here. So you'll see some more information coming from us. Thank you for attending today. We didn't get a ton of questions, but I did want to see if I could answer a couple in here that we have, maybe ask Steve to fill in to what we can do and what he's seen. But one of the questions that I have gotten numerous times is of all the things that we talked about, Steve, and difficulties, what is the most difficult part of an ACO onboarding and getting ready to start submitting and looking at quality reporting?
I would say the most difficult part of an onboarding get ready is really identifying the data sources and the data acquisition strategy and what that looks like. So being able to see where's your data coming from. For example, maybe you have 10 different EHRs. What is the strategy in terms of, are you getting data through potential files, spreadsheets? Are you potentially, or is your partner pulling data from? So I would say the onboarding and the data acquisition strategy and conversations are typically the most important part, and the most lengthy part. But that's something that where we strategize with you to find out what the best strategy is for you, and obviously keep that flexible as um, ACOs and organizations tend to change throughout time. So we definitely partner with you in that, and that's usually typically the most lengthiest process and the most challenging process.
Thanks, Steve. I'm going to make you laugh on this one, Steve, but I'm going to use a basketball analogy as you're a big
Oof,
basketball fan. The best ability is
availability.
availability,
Yep.
right? So, one of the biggest things that I see, and we have a timeline question here from someone too, is that you could have this data strategy, you could think of ways to do this, but if you don't come up to the plate or you don't get to that free throw line, you're not doing what's needed to be done and getting there as early as possible. As I stated, we've had groups that have been working with us for 3 or 4 years already in matching and seeing what they can do. The earlier you are, the most beneficial it is for your practice or for your ACO to report utilizing a system like HealthMonix's MIPS Pro and ACO programs. So you really need to get started now. There is no, I mean, the answer to a timeline question is the earlier the better. I would say by summer, you have to be really working on it. But we have taken ACOs that have joined us in October and got them submitted in February, sometime of the following year. So there are those opportunities. But for me, I think the big part is you have to take those steps forward to really start seeing what those integrations and what your data looks like. And once you have that going, this does become a bit easier as we move along. Um, you know, there is a lot to go over with these ACOs. We're going to have new rules come out at the end of the summer again, which you'll be able to see. We've done some other webinars on measures. We've done webinars on the final rule from before. These are things that you can reach out and see on our website directly. We have a lot of experts here that can help find where you need to be as an organization based upon what we've done in the past. So we need to be able to really work with you to get you going in the right direction as early as possible. I can't emphasize that enough. Coming from the side of working with a lot of these groups as they're coming across the finish line, the more that you delay, the worse it is towards the end. And the more you get done early, the better you'll be. So, from Steve and I, and from the whole team here at HealthMonix, everybody have a wonderful week. If you're enjoying spring break with family and so forth, I wish you fun spring break, and hopefully it's warm wherever you are. It's been a pleasure, and everybody have a wonderful time. Thank you.